Stults, and he really needs no introduction. He's the chief of the General Internal Medicine Department at the University of Utah, and he's going to discuss the latest recommendations in terms of hypertension. Dr. Stults.
Well, thank you. Can everybody hear me? And I'm just looking. Do we have a pointer up here? Is that? I guess this is it, maybe, huh?
That's it, yeah.
And which is the? Is that the? Yep.
This is forward.
Gotcha. Gotcha. Okay. It says danger here. I don't know quite what that means, but I'll see if I can figure it out. JNC8 was supposed to be released this morning at 10 o'clock in San Francisco at the American Society of Hypertension meeting, and on Tuesday they announced that they weren't going to release it for a little bit longer. So we're actually talking about JNC late, not JNC8. Oops, I didn't mean to do that. There we go. So I have no conflicts of interest here. Hypertension remains the dominant contributor to mortality, and that's whether we're talking about developed or even developing nations in the world. It increases the relative risk 2 to 4-fold, and it's not just for coronary disease and stroke and heart failure and peripheral arterial disease. It's also for renal failure, atrial fibrillation, dementia, and even mild cognitive deficits, as we're going to see on the next slide here. I never seem to be able to get that here. That's that one here. There we go. 2/3 of strokes, 1/2 of chronic kidney disease and heart failure, and 1/4 of myocardial infarctions and premature deaths are directly attributable to hypertension, which shortens lifespan by at least 5 years at a cost of $94 billion. Well, there are some newly recognized complications of hypertension. A recent cross-sectional study from Framingham of cerebral MRIs in 579 subjects with a mean age of just 39 found that hypertensive and even pre-hypertensive levels of systolic blood pressure were strongly associated with both white matter microstructural damage and with temporal lobe gray matter atrophy. And those are two cerebral loci that are strongly associated with cognitive dysfunction. This is certainly of some concern. Well, the prevalence of hypertension has not changed in the United States in the last 10 years. It's still 30% of adults, but it is higher in African Americans, as you see, than in whites or in Hispanics. But of particular interest, I think, is the fact that 67% of persons over age 60 in the United States are hypertensive. All of this translates to about 75 million hypertensive Americans. Well, fortunately, hypertension control rates have substantially improved over the last 20 years, from just 27% in 1988 to 47% in 2010, with better control rates in women than in men, better control rates in whites than in African Americans, but especially more than Hispanics, who have the lowest control rates of all in this country. With lower control rates, again, in people with diabetes or chronic kidney disease, particularly if we continue to define hypertension there as 130/80 or higher. Well, these control rates are substantially lower than the Healthy People 2020 goal, which is to get 61% of Americans controlled. But that number ought to be achievable because hypertension control rates in Canada, where they have a very well-developed control program, and even in our own VA system in the United States, are now at 65 to 76%. Unfortunately, there has been no improvement in hypertension control rates in the United States over the last 5 years. Well, that means we have 39 million uncontrolled hypertensives in the United States. 40% of those uncontrolled patients are not even aware that they have hypertension, and another 15% are aware but for unclear reasons remain untreated. These tend to be younger persons, men, Hispanics, persons with decreased finances, but even if they have health insurance, as 85% do, they access the healthcare system very infrequently. To improve their hypertension control rates, we've got to do a much better job of screening at non-traditional sites such as work, community centers, and churches. We need better media outreach about hypertension, and we need to improve access to care. But that's not just by expanding insurance coverage. We need to make our clinic times more available to a lot of these people. Well, the other 45% of uncontrolled patients are treated, but they remain uncontrolled. They're more often older, women, obese, African American, often with chronic kidney disease, cardiovascular disease, or diabetes. And as we're going to see this morning, to improve their hypertension control rates, we need to do a better job first of accurately diagnosing hypertension, controlling for blood pressure variability, measuring blood pressure accurately in the office, and more vigorously detecting white coat hypertension. We need to decrease our own therapeutic inertia, as 65% of uncontrolled patients are currently taking only 1 or 2 antihypertensive medications. We need to, as we'll see, improve our own therapeutic efficiency, and we need to continue to work on patient adherence. Well, how low should we go? Target blood pressures are changing in 2013. For the general hypertensive population, the guidelines continue to suggest targeting pressures below 140/90. However, for persons age 80 and over, the new Canadian guidelines, as well as the 2011 British and American Heart Association guidelines, suggest that we initiate therapy in persons over 80 only if systolic blood pressure is persistently 150 or higher, and that we target a blood pressure of just 140 to 145. For chronic kidney disease, while JNC7 suggested that we lower blood pressure below 130/80, the new Canadian guidelines and the new National Kidney Foundation guidelines have backed off and now suggest that we lower blood pressure simply below 140/90 unless patients have significant albuminuria, which they define as an albumin-creatinine ratio of 30 or more, in which case we go back to less than 130/80. Diabetes, same. People are backing off. The new National Kidney Foundation guidelines and the new ADA guidelines now suggest we simply lower blood pressure below 140/90 or 140/80 respectively, unless for the Kidney Foundation, patients have significant albuminuria, in which we go below 130/80, or in the setting of the ADA, they suggest that we might consider 130/80 in younger patients or patients at particularly high stroke risk. Well, the new guidelines about persons age 80 and over are based on 2 considerations. The first consideration is the HIVET randomized clinical trial that took 3,800 patients age 80 and over whose initial mean systolic blood pressure was 171, and they randomized those patients either to placebo or to the combination of indapamide with or without an ACE inhibitor. The final achieved systolic pressure in the placebo group was 157, and the final systolic pressure in the treated group was 143. Lowering systolic pressure to 143 reduced total and fatal stroke by 30 to 39% in just 2 years, mortality by 21%, and heart failure by 64%. But the second consideration is a J-curve concern. Can we lower blood pressure too far in the very elderly? Optimal blood pressure in persons age 80 and over in a post hoc analysis of the very large INVEST randomized clinical trial turned out to be 140/70. Now, the INVEST trial was a trial of 2 different antihypertensive regimens in 22,000 patients who had both coronary disease and hypertension. And when they looked in post hoc fashion at the subgroup of patients age 80 and over that are represented by the yellow triangles here, they found that the hazard ratio for cardiovascular disease events began to paradoxically increase as systolic pressures were dropping below 140 and as diastolic pressures were dropping below 70. This is the so-called J-curve, as you can see from the shape there. Well, how low should we go in chronic kidney disease? 3 randomized trials randomized 2,200 patients either to the 130s and 80s or below 130/80, and in those trials they achieved the goals they were looking for. But lowering blood pressure below 130/80 in chronic kidney disease patients did not reduce cardiovascular disease events, chronic kidney disease progression, or mortality. The only possible exception to that, and this is low quality evidence I think, is in the subgroup of patients who had heavy proteinuria, greater than 300 to 1,000 milligrams per day. In those patients, lowering pressure below 130/80 still did not reduce cardiovascular disease events, but in the 3 studies, it did slow chronic kidney disease progression by a modest amount. How low should we go in diabetes? Well, this is a post hoc meta-analysis of 13 randomized clinical trials with 37,000 patients, where they looked back at the mean achieved systolic pressures in those trials. And they compared patients who were 135 to 140 with those who were 130 to 135 with those who were below 130. And when they did that, they found that as compared to going to just 135 to 140, if you went 130 to 135, there was a reduction in total mortality and stroke, but not in myocardial infarction or major kidney disease. Lowering below 130 only reduced stroke a little bit further, but none of the other outcomes. Well, maybe a target blood pressure of 130 to 135 is the right place, or if patients have very high stroke risk, maybe below 130 in those patients. Well, how low should we go then? Is just below 140, over 90 low enough? Or should we be targeting at least some patients to 130 or 135? Or can we go too low? And will we find a J-curve with an increase in cardiovascular disease events if we go too low? And does it matter if we're looking at primary prevention patients or secondary prevention patients who already have vascular disease? We simply don't have answers to any of those questions. And this is the reason for the National Institutes of Health SPRINT trial. 9,000 patients in these 3 categories have been randomized either to have their pressures lowered below 120 or to the 130 to 139 range. Myself and the next speaker today are both involved with this trial, and I can tell you keeping people 130 to 139 all the time ain't easy. Well, let's shift gears now and let's look at a more accurate diagnosis of hypertension, and particularly clinical challenges to the clinical validity of office blood pressure. It is a patient's true or usual blood pressure most of the time that actually predicts cardiovascular disease risk. Unfortunately, blood pressure is inherently variable. It changes spontaneously over minutes. It even changes spontaneously over months with the season of the year. As an example, 20% of patients whose initial systolic blood pressure is elevated will have a drop in systolic blood pressure of more than 10 millimeters of mercury just 1 to 2 minutes after that first measurement. And we know that it takes around 4 to 5 office visits before blood pressure stabilizes, and in some patients it doesn't even do it then. A second challenge is that inaccurate blood pressure measurement in our clinics is the rule. It's not the exception. A recent study showed that the mean number of technical errors on manual blood pressure measurement was 4 in 93% of office blood pressure measurements. A third challenge is that even if we measure office blood pressure accurately, out-of-office blood pressure is frequently not equal to office blood pressure. White coat hypertension is present in 20 to 33% of patients with an elevated office pressure, and the inverse phenomena, masked hypertension, is present in 10% of patients who have a high normal office blood pressure but are higher outside the clinic. Well, let's look at these concepts in a little bit more detail. This slide summarizes the key techniques of blood pressure measurement, along with the very substantial changes in blood pressure that occur if those techniques are not followed. As you can see, most of the errors in blood pressure measurement technique falsely elevate the blood pressure, and often to a substantial degree. As an example, if the initial blood pressure is above goal, we should take a total of 3 readings, 1 minute apart. Discard the first one, which is frequently elevated, as we saw on the last slide, by what is called an alerting response, and average the last 2 together. Several studies have now shown that using this approach reclassifies 18 to 34% of patients whose initial blood pressure was high as actually being normotensive with the last 2 readings. Well, as proof that we really need to do a better job of measuring blood pressure accurately in the office, we have here 9 studies with about 9,000 patients. And those studies compared routine clinical practice blood pressure measurement by usual office staff with research quality office blood pressure measurement by a trained nurse in the same patients. And these studies consistently show that accurately measuring blood pressure, on average, drops blood pressure by 10 over 7 millimeters of mercury, and it doubles the hypertension control rates in our clinics. Well, how should we then diagnose hypertension? It turns out even if we measure blood pressure accurately, we need to consider out-of-office blood pressure measurements for many patients. The Canadian guidelines for the last 10 years and the American Heart Association's most recent guideline suggest the following approach. Hypertension can be diagnosed after 2 office visits if blood pressure is extremely high, 180 over 110 or higher, or if it's 140 over 90 or higher in the setting of significant target organ damage, cardiovascular disease, diabetes, or chronic kidney disease. But in all other patients, we really need to do a more vigorous job of ruling out white coat hypertension, which will be present in at least 20 and more likely about 30 to 35% of patients. We can do that in one of several ways. One way is 3 to 5 serial office visits, depending on the level of blood pressure, very labor intense. Another approach is to do 24-hour ambulatory blood pressure monitoring, not always available. And the approach that most of us take is to consider standardized home blood pressure monitoring for 7 days. Well, let's look at these concepts in a little more detail. Home blood pressure monitoring has a number of advantages over office blood pressure measurement. First, it provides a more accurate hypertension diagnosis in most studies because it provides more measurements and we have out-of-office measurements. It clearly provides better cardiovascular disease prediction, as well demonstrated in this meta-analysis of 8 studies with 17,000 patients followed between 3 and 11 years. We now have good data from 6 high-quality studies that home blood pressure monitoring done appropriately can reduce systolic blood pressure by anywhere from 4 to 9 millimeters of mercury. There are some disadvantages still to home blood pressure monitoring. First, we still don't have definitive data that doing home blood pressure monitoring will reduce cardiovascular disease events to a greater extent than office measurement, although I think that data is just about to come out. And there is some expense to it, and again, inadequate patient training in how to do home blood pressure monitoring continues to be the rule rather than the exception. Well, unfortunately, home blood pressure monitors are not always accurate. It is essential to purchase only those monitors that have been validated by one of these 3 international protocols. Those monitors are made by the 3 companies listed here and by a few other companies. And you can get an updated listing of validated devices from any of these 3 websites, although this first one I think is the most useful, from the Hypertension Canada website. Even validated monitors may be inaccurate in a subset of patients, particularly patients who have very stiff arteries. Very elderly patients, patients with long-duration diabetes or end-stage chronic kidney disease, and the monitors may also be inaccurate in some obese patients who have troncoconically shaped arms. For that reason, it's always important for even validated monitors that we validate them in our offices at purchase and every year thereafter. This can be done either with the sequential method in one arm or with the simultaneous method in 2 arms, as described here, simply comparing these against a validated blood pressure cuff in our office. Well, the currently recommended home blood pressure monitoring protocol was initially designed to statistically correlate with the results of 24-hour ambulatory blood pressure monitoring, considered the gold standard. But more recently, it has been correlated with cardiovascular disease outcomes, which is clearly the gold standard. Home blood pressure should be measured twice daily, in the morning and again in the evening. In the morning, within 1 hour of awakening, after micturition and before breakfast and medication intake, after the patient has rested quietly for 3 to 5 minutes, measured twice, 1 minute apart, and a very similar approach followed between 6 and 9 p.m. in the evening. For diagnosis of hypertension or to follow up patients 2 weeks after they've had a medication change, this protocol should be followed for at least 3 and preferably 7 days, so that you're averaging between 12 and 28 readings to control for blood pressure variability. Many investigators favor dropping the first day's results, which tend to be falsely elevated in about a third of patients, and averaging the last 2 to 6 days. For patients whose blood pressure is stable and controlled, you can follow this same protocol every 3 to 4 months for 3 to 7 days, depending on the particular patient. Well, we may have a new diagnostic threshold to diagnose hypertension in the home blood pressure setting. The original goal, which was 135/85 from the American Heart Association and the European Society of Hypertension, was statistically based from cross-sectional analyses. Just 2 months ago, the International Database of Home Blood Pressure Studies has suggested a different blood pressure to diagnose hypertension at home, and this one is based on cardiovascular outcomes. In 5,000 untreated patients from 7 prospective population studies who were followed for a mean of 8 years. And they suggest that if we define hypertension as an accurately measured office blood pressure of 140/90, the equivalent blood pressure to diagnose hypertension at home is 130/85 rather than the 135/85 that we've been doing for the last several years. This ought to be our home blood pressure goal. Well, to be effective, home blood pressure monitoring has to be documented by the patient, then communicated effectively to the clinician, and then the clinician needs to act on that data. And this whole sequence infrequently happens, as it turns out. So patients, as we've seen, need to measure that pressure twice daily for 3 to 7 days. They need to put in all of the readings. And we know patients about a third to a half of the time kick out anything that looks like it's high, not kosher. They then need to transmit that information either as a horizontal paper logbook that I'll show you so that we can easily gestalt mean blood pressure, or if they have a device with a printer, bring in all the printouts, or if they've got the fancy stuff, they can transfer it via computer if their monitor has circuit memory. We need to do this fairly frequently. And then as clinicians or as our team, we need to act on those results both for diagnosis and to adjust treatment. And getting all of these steps done infrequently happens, as it turns out. Well, this is the logbook that we use in our practice. It is horizontally oriented rather than vertical. We put an X for the systolic and the diastolic pressure, and we have bold-faced lines at the diagnostic threshold cutoffs. When you look at those X's across, you can easily gestalt a mean blood pressure just looking at this, because the patients are never going to average them themselves, at least not very often. Well, this is all still very labor-intense, I think. There is a new approach that's been suggested that would redefine office blood pressure measurement by using sequential automated office blood pressure measurements performed on patients who are isolated by themselves in the exam room. There are 3 validated devices, the BP True, the Omron Heme 907, and the MicroLife Watch BP Office, that automatically measure and then average for you either 6 or 3 readings at 1-minute intervals. The theory behind automated office blood pressure measurement done sequentially on patients clinically isolated, there are 3 basic principles. First, because these are fully automated devices, they eliminate many of the technical errors of manual blood pressure measurement that we've just seen. This approach is more accurate. Second, because we're taking multiple measurements, it helps to control for blood pressure variability. It's more reproducible. And perhaps most important, because those measurements are performed with the patient in complete isolation in that exam room, it's been shown to substantially reduce and almost eliminate the phenomena of white coat hypertension. And in fact, as I'll show you, the average blood pressure from these is nearly equivalent to the daytime out-of-office blood pressure on an ambulatory blood pressure monitor study. So this is an example of a study of the BP True instrument taking 6 sequential readings in 284 hypertension patients in a primary care setting. As you can see, the first reading that's taken with the observer present is substantially into the hypertensive range. But the minute the observer leaves, blood pressure drops immediately and substantially, such that the average of the last 5 blood pressure measurements in this study was 11/4 millimeters of mercury lower than the initial measurement taken with the observer present. So what does this pattern mean? Well, we have got 5 studies with about 2,000 patients here that compared routine office blood pressure measurement by usual office staff with automated office blood pressure measurement with the BP True instrument in patients isolated by themselves in the exam room, and then compared that to out-of-office ambulatory blood pressure monitoring looking at the daytime component. As you can see, blood pressure drops dramatically with the automated office pressure measurement in isolated patients, and it's only a couple of millimeters away from the out-of-office blood pressure. That is, automated office blood pressure on isolated patients reduces and almost eliminates the phenomena of white coat hypertension. Well, if we use different approaches to measure blood pressure and diagnose hypertension, we have to remember that we have to use different blood pressures to make that diagnosis. If we define hypertension as a research quality manual office blood pressure measurement of 140/90 or higher, the equivalent thresholds to diagnose hypertension with the other approaches are seen here, with the daytime ambulatory component, with the full 24-hour ambulatory monitor, with home blood pressure monitoring, and remember, if you're going to use those BP True type instruments on isolated patients, you diagnose hypertension at 135/85, not 140/90. Well, let's shift gears now and let's look at some treatment issues. And we'll begin with lifestyle modification. Now, weight loss certainly reduces blood pressure, but it depends on how you lose that weight. A 4-kilogram weight loss from diet reduces systolic blood pressure by 6 millimeters of mercury. But that same 4-kilogram weight loss from orlistat or sibutramine, no reduction in blood pressure. And of great interest, a 16% body weight loss 10 years after bariatric surgery, no big difference from weight loss there in those blood pressures. Exercise, land-based exercise for 90 minutes a week lowers blood pressure by 5/3 millimeters of mercury, but recent studies have not found a benefit to lower pressure in the elderly. For the first time, we have a randomized trial demonstrating that swimming lowers blood pressure. The DASH diet, consisting of fruits and vegetables and low-fat dairy products and low-saturated fat, is one of the most effective of all interventions to lower blood pressure. We now have randomized trials for black tea and for coffee that they do not increase blood pressure, and in fact, black tea might actually slightly reduce blood pressure. Moderate alcohol intake, 2 or fewer drinks a day, has no effect on blood pressure, but the minute you cross that threshold, there are progressive increments in blood pressure that can be quite substantial. 3 prospective studies with 220,000 patients have consistently demonstrated that both sugar-sweetened drinks, but also artificially sweetened drinks, increase the risk of hypertension 13 to 14%. What about vitamin D? Well, here we have a mixed database. 2 meta-analyses of cohort studies could show no effect of replacing vitamin D on blood pressure. But 2 very recent randomized clinical trials suggested about a 4/3 millimeter reduction if patients were indeed vitamin D insufficient or in African American patients. But there is some good news. Dark chocolate, just 30 calories a day, will lower your blood pressure by 3/2. And if you want to go for the gold, 500 calories a day, you can lower your blood pressure by 5/3. So, what about dietary sodium? Dietary sodium has become increasingly controversial, and this has been termed the salt wars. The Institute of Medicine, the Department of Health and Human Services, and the American Heart Association all recommend restricting dietary sodium below 1,500 to 2,300 milligrams a day. And indeed, there are clear-cut benefits. Restricting dietary sodium absolutely reduces blood pressure in both hypertensive and normotensive patients, with the theoretical potential to prevent 11 million cases of hypertension. However, there are increasing concerns about adverse effects of sodium restriction. Sodium restriction activates the renin-aldosterone-angiotensin system. It increases catecholamines, triglycerides, and insulin resistance. So what we really need to know is not does it reduce blood pressure, we need to know if dietary sodium restriction reduces cardiovascular disease events. Over the last 2 years, there have been 6 risk association studies published to answer that question. But there's bad news. 2 of the studies showed benefits of salt restriction, 2 showed harm from salt restriction, and 2 showed a J-curve, with harm at very high sodium intakes and at low sodium intakes. 3 meta-analyses of all this data, same stuff. 1 with benefit, 1 with no benefit, 1 with a J-curve. Well, as you might expect, the scientific response to this mixed database is mixed. The American Heart Association and the British Hypertension Society continue to vigorously support sodium restriction. Other reviewers and investigators think that sodium reduction is not worth its salt, so to speak. And still others suggest we need a huge randomized trial that they would probably be the ones to run to definitively answer the question. Well, as you might expect, the media and industry got the controversy all wrong. The New York Times editorial in June said, and this is the title of the editorial, "Now salt is safe to eat." The British journals were a little bit more vigorous. "Now salt is safe to eat. Health fascists proved wrong after lecturing us all those years." And industry, of course, always is going to do their thing. Campbell soup increases sodium as new studies vindicate salt. Can't win. Well, I still believe in lifestyle modification and I still believe in sodium restriction, but you need good educational tools. And this educational tool from the Canadian Hypertension Education Program at this website is absolutely fabulous. It is at the 6th grade level. It is the best thing going, and this is what I give all of my patients. It covers everything, and it's pretty short. All right, what about drug therapy? Well, what are the optimal first drugs for uncomplicated essential hypertension? Current recommendations from most of the recent guidelines prefer ACE inhibitors or thiazide diuretics or calcium channel blockers. ACE inhibitors are particularly preferred for Caucasians under age 55 because they will reduce blood pressure to a greater extent in this population than thiazide diuretics will. On the other hand, thiazide diuretics, particularly chlorthalidone and calcium channel blockers, are probably preferred in patients over age 65, but especially in African Americans, because as monotherapy, they will lower blood pressure to a greater extent than will ACE inhibitors. Acceptable first drugs would be angiotensin receptor blockers, because there is increasing concern from recent meta-analyses that these drugs might provide somewhat less protection against myocardial infarction than the 3 agents listed here. And agents to be avoided as monotherapy include alpha blockers, which have lesser reductions in heart failure and stroke than any of the other agents, beta blockers, which clearly have a lesser stroke reduction in persons over age 60, and possibly the direct renin inhibitor aliskiren, where there were trends to increase stroke in the recent altitude study. Well, what's the best diuretic, hydrochlorothiazide or chlorthalidone? It is mostly indirect evidence that I think favors chlorthalidone. If we look first at efficacy to lower blood pressure, a meta-analysis of 26 trials with 4,700 patients found that 9 milligrams of chlorthalidone was equivalent to about 26 milligrams of hydrochlorothiazide to lower systolic pressure by 10 millimeters of mercury. Perhaps more useful data comes from this randomized trial this year of 609 patients who remained uncontrolled on a full dose of the new ARB azilsartan and were then randomized to receive either 12.5 or 25 milligrams either of chlorthalidone or of hydrochlorothiazide. In this study, they found that chlorthalidone reduced systolic pressure by 5.6 millimeters of mercury more than hydrochlorothiazide, and it improved hypertension control rates in the study, 64% versus 46%. If we look at efficacy to reduce cardiovascular disease events, we have only indirect comparisons. A network meta-analysis and a post hoc analysis of the original Mr. Fit study suggest that chlorthalidone reduces cardiovascular disease events 21% better than hydrochlorothiazide, but an observational cohort study published from Canada was not able to reproduce that data, and they actually suggest that there were a few more hospitalizations for hypokalemia and hyponatremia with chlorthalidone than hydrochlorothiazide. Well, chlorthalidone has a little bit less practical utility. It's not always immediately available in all retail pharmacies. It comes as only unscored 25 and 50 milligram tablets. And perhaps for me at least, its greatest limitation is it comes in only 3 fixed dose combinations. One with azilsartan, which is too expensive for my money, one with atenolol, a drug I almost never use, and the other one with clonidine, a drug that I use rarely. Well, another important concept is whether we ought to initiate therapy with low doses of 2 drugs instead of 1 drug in many of our hypertension patients. The rationales for this approach are as follows. First, 75% of hypertensives will need 2 or more drugs to control their blood pressure, and 30% will need 3 or more drugs, particularly if the baseline blood pressure is 160 over 100 or higher, or patients are obese or have chronic kidney disease or diabetes. The second rationale is that as compared to high doses of a single drug, low doses of 2 drugs have a greater systolic blood pressure reduction, at least 3 to 4 millimeters of mercury, and clearly fewer side effects. But we have some other data as well. Initiating low doses of 2 drugs improves 1-year hypertension control rates by 20 to 50% in both randomized trials and cohort studies. It reduces 1-year cardiovascular disease events by 11 to 34% in cohort and case control studies, and reduces overall health costs by about 10%. Well, still some cautions. The frail elderly and people with baseline orthostatic blood pressure drops probably are better starting on 1 drug than they are on 2. What about optimal 2-drug therapy? What are the best 2 drugs to combine? The American Society of Hypertension guideline, based on decreases in blood pressure and or side effects and or cardiovascular disease, chronic kidney disease outcomes, suggests that the preferred 2-drug regimens are an ACE inhibitor, or if it's not tolerated, an ARB, combined either with a calcium blocker or with a diuretic, the 2 best drugs to combine. They suggested acceptable 2-drug regimens are a calcium blocker and a diuretic, particularly in African Americans where there may be a very nice reduction in blood pressure. Beta blockers and diuretics, although this is a very diabetogenic regimen, it'll precipitate some diabetes. And then the other 2-drug combinations listed here are also considered as acceptable. 2-drug combinations that are less acceptable and should be avoided: ACEs combined with ARBs, no good. No reduction in cardiovascular disease events, little change in blood pressure, lots of side effects. Don't do it. ACEs and ARBs combined with beta blockers. It's great if you have systolic heart failure. It's great if you're in the first 3 years post-MI, but it doesn't do squat to reduce blood pressure. Direct renin inhibitors combined either with ACEs or ARBs. The Altitude study was stopped early because of increases in cardiovascular disease events with that combination, to be avoided. And then either beta blockers or clonidine with verapamil or diltiazem. These are bradycardic regimens. Well, ACE inhibitors and calcium channel blockers have been compared head-to-head with ACE inhibitors and diuretics several years ago in the ACCOMPLISH study. 11,000 high cardiovascular risk patients were treated for 36 months with one of those 2 regimens. And it turned out in this patient population, the ACE and calcium channel blocker combination was superior to the ACE and diuretic. 20% fewer cardiovascular events, 48% fewer major chronic kidney disease events, despite lowering blood pressure to almost exactly the same level. Now, when they looked at some subgroups, they found the regimens were equivalent for reducing chronic cardiovascular events in obese patients. The differences were primarily in leaner patients. And they found that in African Americans, the regimens were also equivalent. What about preferred 3-drug regimens? We've only got expert consensus, no randomized trials. But clearly, most people prefer a diuretic, an ACE or an ARB, and a calcium channel blocker. But I think these other two regimens have a little data to support them. A diuretic, a beta blocker, and a dihydropyridine calcium blocker, amlodipine, nifedipine, whatever, or an ACE, a calcium blocker, and an alpha blocker that proved very effective in the Ascot randomized trial. Should we be doing chronotherapy? Should we be given one or more antihypertensive drugs at bedtime? Well, two fairly large randomized trials, one in type 2 diabetes and one in chronic kidney disease, randomized patients to either all hypertension medications in the morning or taking at least one medication at bedtime, and they followed the patients for 5 years, 5.4 years. And what they found, not surprisingly, is if you gave a medication at bedtime, nocturnal blood pressure was about 7 millimeters of mercury lower than if you didn't give one at bedtime, but the daytime pressures were the same and the mean 48-hour pressures were the same. But what they did find instead is that the cardiovascular events were dramatically reduced by giving one at bedtime, 75% and 71% in the two groups. Now, based on this, the American Diabetes Association 2013 standard of care says give one or more hypertension medication at bedtime. I still think we need a few more studies, but that's what they say. All right, let's finish today by looking at a little bit on resistant hypertension, which is defined as a blood pressure 140/90 for 3 or more months on 3 or more medications that have been optimally dosed and which include a diuretic. The prevalence of resistant hypertension is increasing quite rapidly, from just 9% in 1994 to 21% in 2008 in the NHANES data set, and that's because the risk factors for resistant hypertension are skyrocketing. More old people, more fat people, more people with chronic kidney disease and diabetes, and we have an expanding Black and Hispanic American population, and these persons are more sensitive to develop resistant hypertension. Resistant hypertension, not surprisingly, is badness, with a 50% increase in bad outcomes in just the first 4 years after it is diagnosed in a recent large study from Kaiser. Well, once we suspect resistant hypertension, we ought to follow an algorithm. And the first step in that algorithm is to rule out what we call pseudo-resistant hypertension. Checking for non-compressible arteries, checking for white coat resistant hypertension, making sure we're on an optimal 3-drug regimen, looking carefully at adherence to medication. If that's true and we're all good, we then consider, but that doesn't necessarily mean evaluate, for secondary causes of hypertension, and we intensify lifestyle and we add appropriate step 4 and 5 drugs. Let's look at each of those steps. Well, we ought to check for calcified, non-compressible arteries. The risk factors for this are very advanced age, end-stage renal disease, long-duration diabetes, calcific aortic stenosis, scleroderma, or various combinations thereof. The clues to this clinically are patients complain of orthostatic dizziness, yet their standing blood pressures are normal or high. The only way you can pick this up if you have a clinical suspicion is to think about those risk factors, and then you have to do an intra-arterial measurement, which will show a low blood pressure while the auscultatory blood pressure is still high. I've seen 2 cases in 30 years, so this ain't out there a lot. A very critical step that cannot be skipped is to check all resistant hypertension patients for white coat resistant hypertension with either a 24-hour monitor study or with home blood pressure monitoring. Here you see 8 studies with nearly 13,000 patients, and those studies consistently show that 1/3 of patients with office-resistant hypertension have white coat-resistant hypertension with normal out-of-office blood pressures. The next step is to be sure that we're on an optimal 3-drug regimen, that we're on maximal tolerated doses of the best regimen, a calcium blocker, an ACE or an ARB, and the diuretic has to be proportional to the GFR. If the GFR is 30 mLs per minute or more, chlorthalidone 25 milligrams a day is your choice. But if it's less than 30 mLs per minute, we're concerned that the thiazides don't work well. And these patients all have increased total body sodium, and here we need to switch to a loop diuretic. The cheap ones, furosemide and bumetanide, are short-acting, And for hypertension, they must be given twice a day, 8 and 5 o'clock, so that they run out of gas by nighttime. Or you can use the more expensive torsemide that can be given once daily. When you dose these drugs, you titrate them to a 4 to 5 pound weight loss. You don't want to prune the patient because bad things will happen then, but you got to get that sodium off to get the blood pressure off. 4 to 5 pounds is about right. You got to monitor the creatinines and the potassiums very carefully. Now, in the Kaiser system, they looked at how well they were doing with their patients with resistant hypertension, and lo and behold, they found that 1 year after diagnosis, 22% were still not on a diuretic, and 57% were not maximally dosed. So really looking to optimize that regimen is a critical step. We have to look for low adherence. As our former Surgeon General said, drugs don't work in people who don't take them, and it's a true statement. We need to simply ask the patient in the clinic, and studies show that that happens in only 30% of visits where the patient's blood pressure is elevated. If we have access to pharmacy refill rates, most of us don't, but some of us do, look at those. Epidemiologic clues to bad adherence: younger patients, males, non-whites, persons with depression. If we're using more than once daily dosing, if we're using the more expensive branded medications, or if we have patients who are kind of worried about side effects. Still, it is very difficult to objectively confirm who's taken them and who ain't. A toxicologic urine screening study of resistant hypertension patients in Germany, where they measured all the drugs that the patients were on in the urine, found that 37% of the patients were completely non-adherent, even though they all said they were taking the meds. Well, the next step is, if we decide we really do have true resistant hypertension, we need to consider but not necessarily evaluate secondary causes of hypertension. And the first one is to look for drugs that increase blood pressure. And the biggest offenders are NSAIDs. NSAIDs, on average, increase your systolic blood pressure 5 millimeters of mercury, but in 10% of patients, they increase it by more than 10 millimeters of mercury. Oral contraceptives, particularly in older women, obese women, women who smoke, or who are of African American descent. Epogens, in about 20% of patients, in proportion to the increase in hematocrit. Corticosteroids in 15 to 20% of patients, and a variety of other drugs, calcineurin inhibitors, the anti-angiogenic cancer treatment agents that we're seeing a lot more of, stimulant anorexic drugs for the epidemic of ADD, which I don't believe in, herbals, ephedra, ginseng, bitter orange, heavy alcohol, cocaine, amphetamines. Got to think about all of those. The second step is the American Heart Association suggests that we look for primary aldosteronism in all resistant hypertension patients, because first, it is present in 10 to 20% of them in 7 trials recently, and fewer than 40% are hypokalemic. Most primary aldo patients have a normal serum potassium. The reason we have to do that is that aldosterone is a cardiovascular toxin independent of the blood pressure. Patients with primary aldosteronism have 3 to 6 times more cardiovascular disease than essential hypertension patients at the same level of blood pressure. So the American Heart Association wants us to screen all of these patients, primarily so they get onto spironolactone, if they have it, because that will block that increase in cardiovascular disease. They are not all that big on evaluating everybody with adrenal vein catheterizations. So how do you do that evaluation? It's very straightforward. You get a mid-morning sitting aldosterone-renin ratio as a screen. The patient has to be off all potassium-sparing diuretics for at least 4 weeks, and they have to have a normal serum potassium. They can stay on the rest of their meds. If the aldosterone-renin ratio is less than 20, it has a very high negative predictive value. You're all done, no PA. But if it's more than 20, it has a very poor positive predictive value, so you got to do more studies. And the study is fairly simple. 3 days of oral sodium loading, 200 milliequivalents per day, a couple of Enchiritos at Taco Bell, get you right where you need to be. You then, after that 3 days, you draw an early morning plasma renin, and you do a 24-hour urine for aldosterone, for sodium, and creatinine to confirm that you have enough, got a complete collection, and that you've got 200 milliequivalents of sodium. If the plasma renin is less than 1 and the urine aldosterone is more than 12, and you've got enough sodium in there, you've made the diagnosis of primary aldosteronism. But if any of these are not true, you don't have it. Once you've got it, the question is, what do you do? Well, most of us think we simply put the patients on spironolactone therapy. CT scans are misleading in 50% of patients because they miss small adenomas and they pick up incidentalomas that aren't making anything. And the only way you can do this diagnosis is adrenal vein catheterization, which is an incredibly difficult thing. It's only done well at a few centers in the country. What about renovascular hypertension? Well, fibromuscular dysplasia is present in about 10% of these patients, but it's primarily limited to women under age 50 with resistant hypertension. And in these patients, you ought to screen them with an MRA or a CTA because revascularization of fibromuscular dysplasia is very good. Lots of cures, lots of improvement. Unfortunately, 90% of renovascular hypertension is atherosclerotic disease. And I think we should primarily look for that if the blood pressure is really truly refractory and the patient has either got kidneys going down the tubes or they've got recurrent sudden episodes of heart failure. These are the patients that I work up. Those patients I will screen with an MRA or a CTA in some centers, but not ours. You can do ultrasound for this. But the bad news is we don't know if revascularizing atherosclerotic renal artery stenosis is useful or if it doesn't work. The two randomized trials so far, Astral and STAR, have found no benefit. The NIH trial, which is much larger and better done, Coral, is supposed to be out this year. So maybe we'll get some better answers. Sleep apnea. 71 to 85% of patients with resistant hypertension have sleep apnea, but 38 to 55% with non-resistant hypertension have sleep apnea. Probably a message there. Does CPAP work? In non-resistant hypertension patients, 4 meta-analyses show it lowers blood pressure 1.6 to 2.5 millimeters of mercury. That ain't too much. We have very limited data in resistant hypertension with some small observational studies suggesting a more reasonable reduction in blood pressure in younger patients who are really sleepy and really heavy. Well, what about treatment? There are two main mediators of resistant hypertension that we know currently: relative aldosterone excess and volume excess. This study of 249 patients with resistant hypertension compared to 53 controls, and they found that the resistant hypertension patients had relative aldosterone excess compared to the controls, and based on brain and atrial natriuretic peptides, they were all volume expanded. So when we look at treatment, we think relative aldosterone excess, we think persistent extracellular volume expansion. Intensive lifestyle therapy does work, particularly with respect to volume. Interesting study, just 12 patients with resistant hypertension. They first put all 12 patients on a 6-gram sodium diet. The blood pressure didn't change. They then put them on a 1-gram sodium diet after a washout period, and the blood pressure dropped 23/9. Can you get to 1 gram of low sodium? No, that's basically a jelly bean diet, and it's going to be really hard in the United States to get there. Aerobic exercise, 50 patients with resistant hypertension, 8 to 12 weeks of treadmill exercise, a reasonable blood pressure reduction. Well, it turns out that aldosterone blockade is near magical therapy in patients with resistant hypertension. 2 retrospective studies, 5 prospective observational studies, 3 randomized trials consistently show blood pressure reductions when these drugs are given at step 4 of nearly 20/10 millimeters of mercury. This is absolute magical therapy. The side effect profile, if you choose the patients correctly, not all that much hyperkalemia, not all that much breast tenderness. Well, this is the current algorithm that most of us use for resistant hypertension. We first confirm that our patients are on a good regimen, an ACE, a dihydropyridine, and chlorthalidone. We then look at potassium and GFR. If the potassium is less than 4.5 and the GFR is over 45, we can feel confident using what has been called sequential nephron blockade. We begin with low doses of spironolactone. If that doesn't do it, we add low doses of furosemide. If that doesn't do it, we add a low dose of amiloride, but we have to check the CAM7 every week while we're initiating therapy. A randomized trial of resistant hypertension patients who had true resistant hypertension, they had 24-hour monitoring to confirm it, found an 18/13 blood pressure reduction and a 58% control rate in these patients with this approach. On the other hand, if you have patients with very high heart rates, particularly if they're over 90 beats per minute, as you'll find in some obese patients, this might be the place where adding a beta blocker as the fourth step makes some sense. If you have patients who have potassiums over 4.5 and GFRs below 45 and heart rates that aren't low, what do? These are a little scary, so there is some observational data that adding an alpha blocker here might be useful, or that using dual calcium channel blockade, adding verapamil or diltiazem to the amlodipine or nifedipine that's already on board up here, these are reasonable approaches. Beta blocker plus alpha blocker, tiny study, suggests that might be another way to go. What does the future hold? Well, maybe device therapy. Last slide here. Device therapy has the rationale of inhibiting the sympathetic nervous system, either by denervating the renal arteries with a percutaneous sympathetic nerve ablation, or, in a more hairy approach, putting in a carotid sinus electrical stimulator to activate the baroreceptors. The Simplicity Hypertension 2 randomized trial, small trial, 106 patients, found a huge reduction in office blood pressure, 32/12, 19% control rate, only minor complications, benefits sustained out to 24 months. The Rios pivotal trial of a carotid sinus electrical stimulator, larger trial, big reduction in office blood pressure, good control rates, 5% permanent nerve deficits. No good. Get those phrenic nerves paralyzed. But I think there's a lot of caution with all of this. If you look at these studies, they aren't great. The suboptimal therapeutic regimens before enrollment, short duration, follow-up on small numbers, and most important, these studies were all based on office pressure. One of the studies did out-of-office 24-hour monitoring and found the reduction not impressive, 11/8 instead of 32/12, suggesting that maybe these approaches are suppressing white coat effect rather than real blood pressure. Let's quit.
We have time for one or two questions.
A question, when you showed the resistant hypertension, you said spironolactone, then Lasix. Question, what happens to the potassium with that? How do we need to monitor that? I mean, using two diuretics like that, isn't that hard on the kidneys?
So, am I on? I can use this one. So the question is, spironolactone and furosemide, are they hard on the kidneys?
Well, yeah, I mean, and plus how do you monitor the potassium? Do you do it monthly?
No, I think, as I said before, I think I check the potassium during the initiation of therapy every week.
Every week.
Once I'm stable, I'll check it once a month for a couple of months, and then about every 3 months. Any diuretic regimen has the potential to prune a patient if you're not careful.
Okay.
So yes, I watch weights. Yes, I watch creatinines. Yes, I watch potassiums frequently. But the most important thing is picking the patients correctly at first. You don't give this spironolactone and these things to patients with low GFRs or high normal or elevated baseline serum potassiums. Can't use them in those subgroups of patients.
Okay, thank you.
Any special considerations in young adults who develop significant hypertension, people in their teens or 20s?
So question is special considerations in young people here. I think the first consideration is to be absolutely certain that you have documented that those out-of-office blood pressures are indeed high. So these are the patients that I really push to do a 24-hour ambulatory blood pressure monitor to feel absolutely comfortable that this patient is truly hypertensive. The second step is I make sure I look at all of the other cardiovascular risk factors because they all add up. And if it's just the blood pressure and the lipids that are good and they're not smoking and all that kind of stuff, then I think you feel a little bit better. How often secondary hypertension workup should be done? I think not all that often. I look at the CAM7. I don't go after anything unless I have clinical symptoms or signs that there's a secondary disorder. So yes, I do a urine analysis and a CAM7 and all those things and a history, but unless I have clinical clues, I don't go looking. Family history, very important. If you have one or both parents, particularly both parents with hypertension, you'll develop hypertension 10, 15, 20 years earlier than your parents will, particularly if you're on a high sodium diet or you're overweight.
Yes, I work in the emergency department, and we often see patients who come in very nervous. They take their blood pressure several times a day, not twice, but 4, 5, 6. And it seems to me that part of the thing driving the blood pressure up is the anxiety of the blood pressure itself. And they'll come in, the reading is 160 over 100, and they'll show up in the emergency department. So what would you advise me to say? I understood you to say morning and night would be ideal. What else would you recommend that we say to those patients who come in?
So I have seen exactly the same patients that you have. Geez, my blood pressure is a little high. Let me take it again. God, it's even higher. Let me take it again. Oh my God, what am I going to do? That happens. That absolutely happens. There are a few patients that I have had to literally stop from doing the home blood pressures because we couldn't get away from that. I often make sure that those patients have a normal 24-hour ambulatory monitor study because patients who are that reactive really do have a higher incidence of getting worsening blood pressure over time. So I look very carefully at them, and I think about 24-hour monitors in those patients to be sure. But I see it as well.
I have one question, Dr. Stults. You didn't say anything about pheochromocytoma.
I didn't say anything about pheochromocytoma. The last one that I saw, I told my resident, there's no way this patient has a pheochromocytoma. They're really rare. The resident proceeded to work the patient up despite my protestations, and he found a pheochromocytoma. I only do pheochromocytoma workups if patients have symptoms or they have the less common paroxysms of hypertension. But I'm looking for episodes of sweating, palpitation, headache. Those are the patients I work up. But if everything else is clean, I don't do the workup for it.
Thank you. Our next speaker is Dr. Raphael. He's on the faculty at the University of Utah in the nephrology department, and I think he's really not quite with it mentally because he grew up in Hawaii and lives here instead of going back home to Hawaii. But in spite of that, he's a valuable member of the nephrology department. I can't tell you how many times I've seen an order in the chart for a renal diet. I'm not sure I know what a renal diet is, and this is all I do is nephrology. So Dr. Raphael is going to tell us what a renal diet is and how to prevent progressive kidney failure